Hello there and welcome to the Inside Health Podcast. I'm James Gallagher. And regulars will know we spend a lot of time chatting about life, medical breakthroughs and how to keep healthy and happy. But no matter how hard we try, eventually our mortality catches up with us. And in our dying days, we often wish for it to be peaceful and at home rather than in a hospital. This episode, we're exploring how friends and family are being taught to help provide end-of-life care so that loved ones get the death they want. It's an idea that's just starting to take off around the UK. And despite this being a potentially distressing topic, or, maybe because of it, the boundless love you're about to hear is something quite beautiful.
When my mum was feeling sick and was in pain, I could administer that on my brother. And you could see the difference within that half an hour. And that was so nice for me and my dad to see, and my brother, that my mum was getting the best care that we could give her. If you've got in pain and you're having to wait hours and that, you can see the suffering that my mum would be going through while we're waiting for someone to come and sort out the medication. So it was a nice thing to be able to make that time as comfortable and pain-free as possible.
In some ways, it is a big change, but in the area where I now work, where it is part of routine practice, it just enhances the ability to be sure that people are very well looked after at home when they die. To see it in action, to hear the feedback, and to know just how big a difference it's made to their lives, it is a great privilege for me.
That's Mark and Marlies, and we'll get to know them both a lot more in a moment. But first, I want you to consider this. At the moment, around 4 in 5 of us say we want to die at home, but many of us don't. And there's lots of reasons for that. Some of us change our minds, or our needs, our medical needs, become so complicated that going to a hospital or a hospice becomes necessary. Another challenge is eventually, towards the end of our lives, it becomes too difficult to swallow pills. So someone needs to come round to our house and inject the medication. And that's Vicky Hughes' job as a palliative care nurse at Betsy Cadwallader University Health Board in North Wales. Vicky, welcome to Inside Health.
Oh, thank you.
Vicky, can you just walk me through the usual process of what happens when somebody's dying and needs palliative care?
When we have established that somebody is coming to the end of their life and that they want to stay at home to die, then normal practice is that they'll be supported in the community by their GP, district nurses, and they have some input from our team occasionally if things are a little bit more specialist. If the person is vomiting or too weak to take their oral medication, we have these injectable medications that can be given to try and manage them symptoms at home.
And because it's an injection, that has to be done by a trained medical professional?
It does, yes. They sometimes put a port in, like a cannula, a little soft tube under the patient's skin, so that then they can administer that medication without having to give an injection every time. They can use this port. So that's traditionally how we've been doing it.
But the issue there, Vicky, is you and your colleagues, you're not in the house all the time, so you're not able to see when you need to give those drugs. It's just relatives that are there.
We have to rely on that relative to ring the district nurses or the out-of-hours GP at night to then inform us that the patient has a particular symptom. They would then have to wait till that nurse became free to then go out and administer that injection or medication. The area that we cover, Conway and Denbighshire, very rural parts. Yeah. So in the night, the nurses are out there in their cars with their torches, trying to find locations. And, they're very busy because they're dealing with other people that maybe have a blocked catheter or a wound that needs attending to.
And how long sometimes do people have to wait for someone to come around to give that pain relief or that anti-vomiting medication?
It does vary. If the nurse is free, it will be as soon as they can. But, we do have instances where people wait up to 4 hours,
That's
possibly
tough.
longer. Yeah, it can be very stressful for relatives and obviously distressing for the patient if we can't get to someone's distressing symptoms in a timely manner.
And does that mean that in practice, despite the fact that people like you are out there providing this kind of care, people end up back in hospital even though they want to die at home.
Yeah, it can do. And unfortunately, it does sometimes end up that people do get admitted, brought in on a blue light to a busy ED department.
Just think about that for a moment. You need powerful pain relief or some other medication, but you're having to wait up to 4 hours before a doctor or nurse can get to your home. Well, Dr. Marlies Pullman, who's a palliative care doctor at Betsy Cadwallader University Health Board, still in North Wales, has been trying to find, an alternative. So, Marlies, welcome to the programme.
Thank you.
You're now one of the pioneers of this project to basically allow more people to die at home if that's what their wish is. Where did this idea come from?
I work as a palliative care doctor supporting people in their own homes. And in 2013, 2014, we asked ourselves whether we should think differently about symptom control in the last days of life, and specifically, what role can relatives and friends play in that symptom control? So we started looking around and saw that it has been done in Australia for more than 30 years. And I think that's where the story started, and we built it from there.
So, Marlies, just tell me exactly what happens. Who are you giving the skills to provide that care to?
We are training the relatives and friends of dying people to be able to give medicines for symptoms that may happen in the last days of life.
One of the first people to be trained was Mark Forshaw. Mark and his brother worked with palliative care nurse Vicky Hughes so they could help care for their dying mother at home.
Unfortunately, my mum was diagnosed with stomach cancer and she was given only 6 months to live. It was 2019, December, just as COVID was kicking off, and we were concerned about how things were going to happen.
And did you have a conversation at that time about and where your mum would like her last moments to be?
We're a very close family, so we did try to have that conversation. My dad and my mum would rather die at home rather than going into the hospital due to the restrictions as well. Dad wouldn't have been able to visit mum, so that would have devastated him. So They both decided rather my mum died at home.
And Mark, in those final months, how much care did your mum need?
First few months, she wasn't too bad, but as it got near the 6 months, it seemed to get worse and worse. So she was constantly being sick.
Yeah.
It got to the point where as soon as she would take the tablets, she would be sick. So they weren't really getting absorbed. And then obviously I had to try and mention that to Vicky.
And so, Vicky, you could see this all happening. Mark's mum can no longer take the oral drugs. What happened next?
So, we initially did give her an injection of anti-sickness medicine, and then we put a port, the soft tube, under her skin so the district nurses could then administer the anti-sickness to Mark's mum as and when she needed it. But again, unfortunately, there was long waits for that to happen. So we approached Mark and his brother and we asked them if they would like to be trained to give mum her medication via the little port under her skin.
Mark, Vicky comes to you with this idea. How did you feel about that? Because it's a huge amount of responsibility, isn't it?
It was a bit nerve-wracking thinking about it. But on the other hand, I spoke to my mum and my dad about it, and it was what was best for my mum. So it was a no-brainer in the end.
Vicky, can you just walk me through the training? How you go from taking a son and giving them the skills to be an end-of-life carer?
Yeah, we do a risk assessment and we have to make sure that Mark's mum's happy for Mark and his brother to be doing this. Then we have a little training box, a little plastic box, and we have some practice ampules because the medication comes in glass ampules, so they've got to learn how to take the tops off. And we have some syringes and then the port on top of the plastic box so that then they can practice using the syringes, filling them up with water, so they get used to the feeling of pushing the medication through the port. And then we teach them how to draw up the right amount of volume from the ampule. Because obviously there's 4 medications we generally use and they can have different volumes.
And those 4 meds you mentioned, what are they for?
So we have something for pain, something for agitation and anxiety. Then we have something for nausea and vomiting. And then we have something for noisy breathing. We then try and teach the relative how to recognise them symptoms.
As I say, that feels like that could be one of the difficult bits.
Nausea and vomiting, that's quite obvious to recognise. Pain can be easy to recognise if the patient can verbally tell you. So we're looking for grimacing and things like this if they can't speak. Sometimes agitation can be a difficult one because it's difficult to see if someone is actually agitated, or they may just be uncomfortable in the bed or need repositioning or have a dry mouth. But these family members have been looking after their relatives for normally quite a few months, and they've really got to know their relative symptoms and how their relatives react to certain things. So they do know their relatives probably better than we do.
So, Marlies, we're just listening there to Vicky describe the medicines that can be given. It just leaves me wondering about safety precautions. Like, are there limits to how much medication that can actually be given?
A relative or a friend can give up to 3 medicine doses per symptom in 24 hours. So it's all covered in the training for them to know what to give at which time and at what dose.
And if they need more than that?
They need to call for help from the doctors and nurses to see, are we at the right dose? Should we think differently about medicines and how to give the medicines? So that's why it's limited at 3 per symptom.
Some people do have like a pump that will just continuously dose them as well, won't they?
That's right, especially if somebody needs quite frequent doses. There will be this process to think, should we put some of that medicine continuously via pump? Of course, still then the as-needed medicines can be given to top things up.
And do you see every dose that's given? Like, is someone keeping an eye on everything?
Yes, so the program that we are running in Wales have a bespoke diary that the relatives and friends complete for every time they give medicines. The time, the medicine, the dose, but also what level the symptom was before they gave the medicine, what level the symptoms are 30 minutes afterwards, and also how confident they feel about it and whether they called for doctor or nurse backup.
So even though you're training these relatives, they're far from being on their own when it comes to giving these drugs.
That's absolutely correct. So they can give the medicines, but have somebody to call 24 hours a day for support. And I think the other really important thing, if I haven't said that already, James, is the relatives and friends are never under any obligation to give the medicine at the time if it doesn't feel right. They can always call for help.
Mark, can you remember the first time you did it on your own?
Yes, I can remember the first time. It was very nerve-wracking because you're always thinking, have I done the right thing? Have I done this? Have I done the right measurements? But I knew it was best for my mum, and my dad was watching as well, which didn't help. For the first few times, we had the district nurses watching us while we did it. So when the first time came, I did it on my own. I'd done it a few times, so it was support all the way through. And I could have always phoned the district nurse or Vicky and say, look, I can't do this. And then they would step in. As I got on with it, I got more confident, and I can see the benefits for my mum as well.
What were the benefits for your mum?
When my mum was feeling sick and was in pain, I could have administered that on my brother, and you could see the difference within the half an hour. And that was so nice for me and my dad to see, and my brother, that my mum was getting the best care that we could give her.
How long did you do it for?
It was about 6 weeks, if I remember correctly. And then as mum got worse and worse, of an evening we administered a bit of sedative to help her sleep.
So far in Inside Health, we've heard how people in their final days can be left waiting hours before they get the drugs they need to relieve pain, stop them vomiting, ease agitation, and help with their breathing. And we've heard from Mark, who was trained to provide those drugs for his mum so that she could stay at home rather than go to a hospital. But if you're like me, you're probably thinking that some of these drugs are incredibly potent, such as the opioid painkiller morphine. So how do we make sure that it's safe to hand this responsibility onto friends and family?
Hello, I'm Dr. John Martin. I'm a palliative medicine consultant working in London.
John, welcome to Inside Health.
Thank you.
I suppose one of the drugs that people will raise an eyebrow at being in people's homes is morphine. I mean, is there a concern?
I don't think they need to raise an eyebrow, but it is something to think about. Pretty much all medications have side effects. And when you're thinking about giving a medication, whatever it is, you're balancing the benefits that that medication can bring with the risks of side effects that come with that medication. Most of the side effects of morphine are inconveniences, really. You might get some dry mouth, constipation, and those need to be treated. Other side effects that people worry about, such as sleepiness, they tend to only occur initially when somebody starts on the medication, and then it goes away. Same with nausea.
But one of the side effects, John, that people will be concerned about, and you don't have to go Googling morphine for very long, is the idea that it can hasten death, that it can adversely affect people's breathing and actually be fatal.
Okay, so I want to kind of split this into two parts, if that's okay. So the hastening death idea has been around for a long time. If you look at the evidence of when morphine is used properly by people who know what they're doing, then all of the evidence suggests that it does not hasten death. So I really want to put that one to bed because it's just not real. What is real, though, is that along with the inconvenient, more minor side effects, there are more serious side effects that can occur. So people can get hallucinations, they can get jerking of their limbs, but ultimately that can progress through to an impact of the medication on breathing. So somebody's breathing can become depressed, and if that's not addressed promptly, that can lead to the death of the individual. Really, we don't see the progression to respiratory depression very often because we pick it up earlier. We pick it up at the point where somebody's starting to get hallucinations or starting to get jerking. And we intervene at that point to ensure that things don't progress to the point of respiratory depression. It is worth saying that right at the end of life, you can get changes to the pattern of somebody's breathing. That's not a morphine side effect. That's what we commonly see when people who are dying.
So, John, I have no doubt that you would spot those early signs of morphine side effects. But we're talking about friends and family here, aren't we? So can we still be sure those signs are going to be picked up?
There's so much security built into the system around friends and family giving these medications at home that the doses that the relative is giving and the number of doses that are allowed are really within very safe limits. But they're also required to note down changes that they might see, and those get reviewed on a daily basis by the healthcare professional going into the house, and the medication doses are adjusted accordingly.
So while that friend or family member is giving the drugs, they're not in charge of the size of the prescription.
Exactly. So they are the hands, if you like, and the eyes and the ears, but they aren't making the decisions about what the dose should be and how often it should be given.
John, are we as a society comfortable with giving morphine into the hands of admittedly trained but to family members and to friends? And I'm just thinking of the long shadow that Harold Shipman, a murdering GP who used morphine to kill some of his patients. It's cast a long shadow over medicine, hasn't it?
It has, yeah. Harold Shipman was not somebody who was trying to balance the morphine dose against the amount of pain, and it happened to go wrong a lot. He was deliberately giving far too much, and so he was a murderer. I'm very comfortable with family members who are trained to give these medications and who are trusted by the people training them to do so safely. I think that's perfectly fine, and it really overcomes this other, in my view, much bigger risk that somebody's pain goes untreated or undertreated. And we can overcome that by allowing family members to give injections of medication at home. There's lots of security around it, lots of safety around it.
Thanks, John. And Marlies, back to you again, because you're pioneering this idea and you're talking to families. I'm sure they've got similar concerns about drugs like morphine. So what do you say?
We explain to them that we are using medicines that very commonly used for people in the dying phase, that we choose the doses very carefully, and therefore we are not worried that it will cause any harm to their loved one if it's used in this careful way.
Just while we're on that thought, because obviously it's a hugely emotional time at the end of life, and I'm just wondering if there's any kind of challenge around guilt or anything around the final drugs, the final doses that get given to somebody, and worries that you might have actually contributed to your loved one's death.
Absolutely. That is a very, very important part. So we discuss very carefully with relatives and friends whether the medicines can cause serious harm to their loved one or hasten death. And we explain it in this way, that there might come a time when they're giving the symptom relief medicines, when their loved one is very ill and will die very soon. And it might mean that the time when their loved one dies is very near to when they have last given them medicines. And that it's very important for them to know that the two things are not related, and the medicines given in these careful doses has not ended their loved one's life. And we know it's such an important topic that we do this in the initial training of the relatives and friends. We remind them of this in the time that they're giving the medicines, and we also often chat about it.
John, think about the whole idea here of training family members to provide drugs to keep dying people in their own homes in their last days. Is that a good idea or a bad idea?
I think it's a great idea, not to wish to be too political about it, but I think it's a shame that our NHS and services at home can't do that for people in an adequate way. But given that's where we are, I think it's a great way of overcoming this other risk that I was talking about before, which is that the person has untreated pain or even can't stay at home because of pain when home is where they wish to be. You know, it's not without concerns, but given all the care that goes into setting this up, I think is a very useful thing to be happening. And in some countries, it's absolutely commonplace.
For you, what are the concerns?
One is in how do we choose those families that we're going to offer this service to? Because there will be some families, they are more of a chaotic household, or they might have people coming into the house who might not be trustworthy. There may be various different things happening that make it less secure.
So, John, would that include, for example, if there was a history of drug abuse in that household?
Yes, it might well include that. But it's true to say that everybody who's coming to the end of their lives has these kinds of medications in their house. So the difference here is who gives that medication. And more in London, what we're having to do is provide small safes so that the medication in the person's home is locked away and is only accessible then to the healthcare professional who comes along to administer that medication. But if it's a family doing that, then they obviously need access to the medication.
How much do you see this being driven by the state of the NHS, and how much by it's a good thing for some families anyway?
Well, my own experience is that we've done this in the past where we simply couldn't get hold of staff to provide that care at night, short of calling for an out-of-hours GP to come along. So it was driven by a lack of services. And that situation changes all the time in different areas, but it's also driven by the desire to ensure that people at the end of their lives are not suffering needlessly. You know, they are in comfort.
Do you think this is going to become standard practice up and down the country?
I'd like to see that happen. There are some countries where this is absolutely standard practice. And I think that's to be welcomed as long as the safeguards remain in place.
John, thank you so much for coming on.
Thank you very much.
Now, Melise, I know some people will be listening to this and thinking, is this just about the benefit to the person that's dying and to their family? Or is there some element of NHS cost cutting and saving, and basically this is something the NHS should be doing and it's being loaded onto families?
That's such a good question, and one that we often consider amongst ourselves. The NHS cannot give a doctor or nurse to be in every dying person's home for 24 hours a day. And friends and relatives wish to take on these tasks and wish to be trained for these tasks. And what we've seen is that it can work really, really well if NHS services and relatives and friends work very closely together as a team to make this happen and to value each other's roles. And I think that's why it can work so well.
And Melise, remind me, how many families and friends have gone through this process so far?
In North Wales, 62 households had dying people being given medicines by their relatives and friends this way.
And that's just in North Wales. What about the rest of the country?
It is also active in Mid Wales, in Powys, and increasingly in England and in Scotland as well.
Is this going to become standard practice across the country soon, do you think?
I think we are working towards this. So all the areas in the UK where this is active, the doctors, nurses, managers, pharmacists are working together to learn as quickly as we can about these programs in the UK setting, to make them as good as they can be, and in due course that everybody who could benefit from it is offered it. But I think it will take a little bit of time to carefully implement this everywhere.
How big a change would that be in palliative care?
In some ways, it is a big change, but in the area where I now work, where it is part of routine practice, it just enhances the ability to be sure that people are very well looked after at home when they die. So it doesn't feel like a change anymore.
Marlies, what's the reaction been like? Because it's quite an emotional thing for families to go through. And I just wonder at the end, when they look back, was it a thing that they were glad that they did?
It's been enormously positive from relatives and friends. That said, we know it's new to most of the UK, and we think that's the reason why we see that many doctors or nurses across the UK are still hesitant about this. So what we've done in North Wales is to be very careful about how we implement it and take it at a slow pace, learn from the outcomes, keep a close eye on things, improve the program, and work our way towards more people benefiting from this in due course.
Marlies, thank you.
Thank you.
Remember Mark Forshaw, who was one of the first people to give this care to a dying relative? Mark and his brother looked after their mum for 6 weeks, safely medicating her as she needed, and they were able to keep her at home.
At like 1:30 in the morning, I got a phone call from my dad saying, Mum's not too good. So me and my wife went to see my mum. She was a bit agitated, so we checked, because when we're doing medication, we checked the books because we write everything down when we've done it and everything to make sure there's a certain amount of time in between giving each medication. So we administered some sedative to calm her down. That was like 1:30 in the morning. So then we went home and then we went to see her the next day. Anyway, she seemed to be not too bad. We'd also tweaked the anti-sickness, so we're only giving it twice a day rather than 3 times a day, and it seemed to be working. But you could see she was getting more and more withdrawn. You know, she wasn't moving much. She used to open her eyes more, so it was more of just blinking, really. And then about tea time, he said, "Try Mum," and give her a kiss and everything, and we all left. It's like as if she knew, because she knew we'd gone, and she was just in the room with my dad. And she passed away in my dad's arms, on it, just them two in the room, which I thought was what Mum wanted as well.
Just a brief thought, Mark. Did it make a difference to the grieving process, having been so involved?
It did. Because Mum was with us, we know she was deteriorating day by day, but because we were with her, it prepares you for the fact, because you can see it happening. What helps with us to accept it more as well, that's the fact that we looked after her and we know how comfortable and how relaxed and how pain-free she was in her last time.
Thank you to everyone who took part in an emotional Inside Health podcast with me, James Gallagher. And thank you for listening. And thanks to producer Beth Eastwood and studio manager Michael Millam.